So good evening for everyone. I try to keep the time. Thank you for inviting me and giving me possibility to be here. This is the very first time, and hopefully you will enjoy my strange topic. I put the first question: why to make problems for you with infectious diseases and histopathology? Because my scientific interest is in infectious diseases in OBGYN, so this was one reason, and I wanted to bring here for today a topic with a practical implication for everyday practice. So this is a severe chorioamnionitis, is a severe disease, infectious disease, and the bedside diagnosis, let's be frank, is really challenging. In addition, its prevalence, have a look, it's even higher than that of preeclampsia, because preeclampsia is diagnosed in less than 3.5% of cases, so probably we do not know. However, it is quite a relevant disease. So in my lecture, I would like to speak about the heterogeneity of the definition of chorioamnionitis, then focus on histologic chorioamnionitis, and then go into clinical implications by a practical example. So by definition, there is a heterogeneity, at least because there are at least 3 different definitions of it, by microbiology, by clinical terms, and histopathology. And they are not covering each other in every case. So microbiology is still simple because the presence of bacteria of otherwise sterile amniotic fluid is supposed to be amniotic fluid infection. There are some synonyms for that. And in addition, we know very well bacteria that are most commonly cultured from preterm and term pregnant women with amnion infection syndrome. In clinical chorioamnionitis, the definition is simple because everybody knows it from textbooks. There is a trias, however, with maternal fever, with fetal tachycardia, and additional maternal criteria, including preterm contractions and preterm premature rupture of the membranes. However, a great majority of cases is of subclinical course, so it is again hard to define and diagnose. And now we can focus on the histologic chorioamnionitis that describes the processes leading to intrauterine infection. Historically, it was just focused and concentrated on the neutrophil infiltration of the chorioamnion and the space, and then have a look. Here are all the organs that might be affected by infections and neutrophilic infiltration, like the placental disc. It is called anvillositis. Fetal membranes, adjacent and not adjacent to the placental disc, it is called chorioamnionitis, and the umbilical cord itself, that is phunyzitis. Histology has the advantage to study both maternal and fetal immune response to infection, and then it helps to solve the problem what has happened during pregnancy. Unfortunately, besides infections, there might be neutrophilic infiltration of these anatomical sites in cases of the absence of bacteria. And in these cases, we call it inflammation or inflammatory response. Just to identify this heterogeneity in the definition of even in histologic chorioamnionitis, just a couple of years ago, it was introduced a new expression. It is triple I for delineating intrauterine infection, intrauterine inflammation or inflammatory response, or both. This expression is not yet widely used in clinical practice, and we clinicians still call it clinical chorioamnionitis. However, III is able to describe this heterogeneity. Let's focus on histologic chorioamnionitis. By histology, we can make difference between the maternal and fetal involvement. Because in women, in pregnant women with a baby boy, the leukocytes can be differentiated, whether they do have XX chromosomes or XY chromosomes. If they have XX chromosomes, it means these leukocytes of maternal origin, and XYs are of fetal origin. So, from these studies we know that maternal infection and fetal infection is different by the site, anatomical site, and I will focus on it. Histologic evaluation of the placenta after birth or delivery is able to conclude whether maternal or fetal infection or inflammatory response has been involved, whether the mother was affected as well, if the fetus was affected, to what extent, so severity of the infection, and this severity and localization might have some implications for the future and future neurodevelopment status of the neonate and for the neonatal health itself. There are many staging and grading systems, but the most well-known is that of Redline, who introduced it some 20 years ago, and staging is for the anatomical progression of the disease, of the inflammatory process, while grading is the number of neutrophils, so the severity of the infectious process. Of stages, there are altogether 3 stages, 1 through 3, stage 3, and of the grades there are only 2. So the maternal inflammatory response can be staged as by the localization, whether it is localized to the decidua, only onto the maternal side of the pregnancy, or involving the chorioamnionic membranes, the membranes, the outer and the inner membranes, or the placental disc, so intervillosities. You can see the different stages, and necrotizing chorioamnionitis is the most severe form of it. I will show you also by pictures and slides. Grade 1 and grade 2 is defined by the number of leukocytes infiltrating the anatomical sign. Have a look how the process is going on. So the migration of the PMNLs, the polymorphonuclear leukocytes from the placental blood, this is the decidua, into the fetal membranes, and now you can see how it progresses. In this slide, you can even see the different stages of chorioamnionitis that you can see by placental histology, and also the maternal. These cases are always maternal involvement. In the chorioamniotic space, there are only maternal leukocytes. If the infectious process reaches the placental, the fetal side of the placenta, that's the chorionic plate, and the vessels are involved, then fetal involvement is also demonstrated, as with that of funisitis. In early stages, so this is stage 1, in early stages of a fetal infection, only umbilical phlebitis is seen. Second step is the presence of neutrophils in the wall of the arteria, and the progression, if the progression you see it in the lower part and part B of this picture, then you can see the involvement of the umbilical cord that is already stage 3 infection. In cases of stage 3 phoenicitis, in terms of clinical aspects, there is a severe septic fetus because it is as closely associated with a high concentration of interleukin-6 and MMP8 levels in the amniotic fluid, and it reflects severe chorioamnionitis. On picture, if we go into detail, you can see stage 1, stage 2, and stage 3 phoenicitis. The stage 3 form, you will see the heavy infiltration of the arteria together with a thrombus in the middle of the picture. So this is really a severe case with fetal sepsis. Stages of the amniotic fluid invasion, it was introduced by a different author, by Romero and his co-authors in the late 80s, and it is accepted and not changed over the last couple of years. And as the number of stages is increasing, then the severity of the infection and the involvement of the fetus is harder and harder. And by the end, as a fetal inflammatory response syndrome will develop with the involvement of all or almost all fetal organs. What clinical implications these possible data in placental histology might help us? Well, if we can read placental histology well, then by the topography, so the anatomic site involved, and the severity, it is by stage and grade of the infection, we can see maternal and fetal involvement. And in cases of adverse neonatal outcome, we might answer the question whether the disease developed before the onset of labor or during the labor, the course of labor. And anything that happens during the course of labor, you know, it is up to the obstetrician. So sometimes it has some forensic advantages as well. So just to demonstrate it to you, I brought one example from my forensic advisor's history or career. I stopped my activity in this field many years ago. However, can you see on the slide the CTG of this patient? Yes, this is, she is a 32 years old nulli gravida. I was asked there for giving an answer because of cerebral palsy of this newborn. So she is a 32 years old nulli gravida presenting 4 days after term at delivery suite. She had repeated courses of antibiotics for severe recurrent pyelonephritis, where also the bacterium was identified, and it was E. coli. She had regular contraction at the time of admission every 7 minutes. She had mild bleeding for the last 12 years, probably a sign of dilatation. That was for 2 centimeters, and a meconium-stained amniotic fluid was diagnosed. At the time of admission, there were signs of fetal hypoxia on CTG. Probably it is clearly seen there, yes? There is a very narrow oscillation, and there is spontaneous deceleration as well. So after 2 hours, the situation was still the same, the oscillation, so that was a silent CTG, and on this picture you can see more than 1 decelerations. And then 6 hours later, she delivered of a neonate, a male neonate. You see the data, who had to be transferred to the neonatal intensive care unit. He was treated by hypothermia, and 3 years later, cerebral palsy has been diagnosed, and the doctors and the team and the hospital has been invited to court for 100 million forint cash as a penalty, that is equal to 300,000 euro. But this is a fortune in my country, and also for 1.2 million, this is 4,000 euro per month until he is still alive. So it was a great challenge for the hospital. Fortunately, not the clinician who was responsible for the delivery, because of course, who cannot identify that this is a jeopardized neonate or fetus, he should have been performed a C-section at the admission, at the time of admission, or at least 40 minutes after that. However, the leader of the team in duty sent the placenta to the histopathologic department, and these guys had the advantage, they had placental histology. Let's have a look at the data. So by histology, a massive necrosis involving the intervillous space, so from the placental disc, the intervillous place, and massive necrosis has been diagnosed as a hypoxic injury. The question is, when did it happen? In the umbilical cord, there was a grade 2 arteritis. This picture is from the woman. I got it from the histopathologic department. Have a look. At the middle of on the left-hand side, here it is. On the left-hand side, here you have again the thrombus. Can you remember? The presence of a thrombus together with a periarteritis is a severe form, equal to the presence of high levels of interleukin-6, MMP8, demonstrating sepsis of the fetus before onset of labor. And probably this sepsis was due to the repeated infections by E. coli, to the production of endotoxins, and probably it was as a consequence of these repeated maternal infections. There are some additional pictures and slides demonstrating the involvement of the umbilical cord. So thank you very much for your attention, and I hope you enjoyed how placental pathology can be used in everyday clinical practice. Thank you.